Again, we're going to do lectures 5, 6, and 7. Should be able to get through all of those today in the 2 hours. I'll have you tomorrow morning for 2 hours, and then tomorrow afternoon again for 2 hours. So lots of my monotonous vocal chords for you guys. Apologize in advance. How did we feel about the lab this morning? Great. Any feedback? Was it useful? Not useful? Useful? Anything we could do differently? Do you guys think? You can think of anything. You can come up during the break and just let me know. We appreciate feedback for that. Trying to make it better. I will say, I've done this for 3 years, and this was by far the most smooth lab that we've had. So kudos to you all. Thank you for participating and being great soldiers, sailors, airmen, and no Marines in here. Okay. No crayon eaters in this class. All right. We'll get started with there's no Marines in here, right? No. There have been in the past. That's always interesting. All right, so we're going to start with the cornea in this first lecture. Here's what's on the PANTS blueprint. Under the corneal disorders, cataract is listed. That's not a corneal disorder, but that's how the PANTS blueprint lists things. Cataract is a lens disorder. I don't know why they put it in cornea, but so we're not going to talk about cataracts because it's not a corneal disorder. We'll talk about that later on today in a different lecture. All right, this is what we're going to talk about: ulcers, keratitis, different corneal pigmentations, and then recurrent corneal erosions as well. So anatomically, just again a review, the cornea is that clear surface in the front of the eye. All of you hopefully were able to appreciate the cornea under a microscope today. And the prefix for cornea is kera. So keratitis is an inflammation of the cornea. Pretty simple. Okay, under an electron microscope, we can see the different layers of the cornea. 5 layers to the corneal structure. The epithelium, Bowman's membrane, the stroma, Descemet's membrane, and the corneal endothelium. There's a mnemonic that we use for our students. I don't care that you know the individual layers of the cornea, but every blue Smurf dies eventually is how we remember those 5 layers. Every blue Smurf dies eventually. Epithelium, again, is that layer that regenerates. So if you scratch your eye, if you get any sort of injury to the eye and the eye starts to hurt, corneal abrasion, that epithelium is going to be not fully intact. And it's going to be painful until that epithelium re-epithelializes. And it takes, depending on how large the corneal defect is, a couple hours up to maybe 24 to 72 hours for that to fully heal. When you get PRK, that's a pretty large epithelial defect that they're putting on your cornea. And that's why it takes a few days for that to fully heal and regenerate. But it heals pretty fast, and that's great, because if it didn't, you wouldn't be able to see very well. The stroma is the thickest part of the cornea, as you can see there. Okay, that's the area that they're going to remove when they're doing refractive surgery. So LASIK, PRK, SMILE. That's where the tissue is removed during refractive surgery. That does not heal, but it does scar if you get a scratch on there. And those scars are going to be permanent and potentially visually debilitating if they're located over the visual axis. And then the endothelium is an important layer of cells. It's just a single cell layer thick. Those cells act as pumps and they keep the cornea clear. The cornea is clear because number one, it doesn't have any vascularization to it. But number two, it's hydrated to a very specific level of hydration. It's about 75, 77% hydrated. If it's more hydrated, it's going to swell and become not clear. And if it's less hydrated, it's also going to become not clear. So the endothelium is a really important layer, and it just is essentially a pump. It pumps liquid in and pumps liquid out to keep the cornea at a certain level of hydration. Okay, so the first disease we're going to talk about is a pterygium. Pterygium, okay? Again, the P is silent just like in ptosis. Pterygium, not a pterygium, just pterygium. So you can think of a pterygium like another word that begins with P that is silent. And we're thinking prehistoric dinosaurs, like pterodactyl. Okay, so you can think like a pterodactyl, they had wings, right? And a pterygium is essentially a wing-like lesion that invades across the cornea. We talked about a specific type of lesion on the conjunctiva that is produced by exposure to ultraviolet radiation and sun and dust, wind. What was that called? The one on the conj? Pinguecula. Yeah, very good. That's written right up there. Good. You guys are reading, paying attention. So a pterygium is similar in nature to a pinguecula in how you can get it. But a pterygium differentiates itself from a pinguecula in that it spreads onto the cornea. So we can obviously appreciate why this would be a little bit worse than a pinguecula because it's growing onto the cornea here. And so you can see some pictures here. These are pterygium because they are growing onto the cornea in that wing-like manner. This pterygium right here, perhaps not quite as bad as this pterygium here. This one on the bottom is covering the visual pathway. So it is going to be hard to see through that, right? You can't see the iris underneath. You can't really see the pupil underneath that. That means the patient's not able to see out of that. So it's going to be visually debilitating for that patient. This other one on the top, not necessarily so much. So that might just be observed for the potential to spread. But they may not require treatment for that top picture because it's not necessarily affecting the patient's vision yet. So the way that they treat these pterygium, if it's just like the top picture here, is just usually with artificial tears. It's similar to how we treat a pinguecula. Really just artificial tears, educating the patients that they should probably wear their sunglasses when they're outside so that UV light does not continue to exacerbate the pterygium to make it grow more. And then the tears are used to keep the eye hydrated in case there's dust or wind exposure to that eye. If you have a pterygium like this bottom picture here, that's going to need to be surgically excised. So surgical excision for pterygiums will occur when it's causing visual issues. Now, obviously, if it's growing over the visual axis, that's going to cause visual issues. But if it's not necessarily over the visual axis, but it's pulling on the cornea, that's going to change the patient's prescription and constantly change it. They'll also excise the pterygium in that case. Pterygium excision is great because it removes the pterygium. It's not great in that the pterygiums will tend to regrow in about half of the cases. The pterygium will just grow back, so it'll either get excised again or hopefully it doesn't grow quite as far as it did the first time. But ophthalmology is going to excise those, so you have to put that consult in to ophthalmology if it's affecting the patient's vision. So you want to take visual acuities when you have a patient that comes in complaining of a pterygium, and you put the consult in. Okay, next we're going to talk about corneal erosions. We're going to cover recurrent corneal erosions and just like almost a keratitis type corneal erosion. The recurrent corneal erosions we'll talk about in just a sec, but essentially anytime you have damage to the corneal epithelium, it's called an erosion or like a keratitis, punctate keratitis. And you can see this picture here on the bottom, all of that sodium fluorescein stain is embedding within the cornea there. That is an area where the epithelium is not fully intact. Okay? So if you've got constant dry eyes, what do you think may have caused this patient's dryness in that inferior third of the cornea there? Sort of, you're on the right track. It's a lid disorder. Think of like a lag ophthalmos. So this patient probably doesn't have a complete blink. So that cornea, that inferior third of the cornea is just constantly exposed and really dry. Okay. There's other inflammatory disorders that can cause that, but if you got a staining pattern like this on that inferior third of the cornea, that's probably due to an incomplete lid closure or lag ophthalmos. Corneal ulcers are extremely painful, okay? So we'll come back to recurrent corneal erosions here in just a sec. Corneal ulcers, jump into a different type of disorder, are extremely painful. It is a tiny little white spot that you can definitely see under the slit lamp if you have access to the slit lamp. Or sometimes they're so white that you can actually see them with the naked eye. So a patient comes in, you're just looking at their eyes, they've got a white dot on their eye, it's probably a corneal ulcer. Okay, that ulcer is going to stain with fluorescein. So if they're in pain and they have a white dot on their eye, that's going to be a corneal ulcer. A lot of times these are a result of bacterial infections because the patient either sleeps in their contact lenses or doesn't have good hygiene when they're putting their contacts in. They don't wash their hands, got dirty hands, and they put their contact in. Or they went swimming in their contact lenses. There are many gross bacteria in swimming pools that we don't want in your eye. It's not a problem usually if you don't have your contacts in because you just blink out that bacteria. But when you have your contact lenses in your eye and you're swimming, there's a tendency for that bacteria to get sandwiched between your contact lens and your cornea, and that's when you have issues. That's when the bacteria just starts to eat into your cornea, causing you pain and vision issues potentially. Hopefully, it's not over the visual axis because you can actually go blind from a corneal ulcer if that scar is directly over the visual axis. So don't swim in your contacts, don't sleep in your contacts, wash your hands before you put your contacts in. Use common sense. Okay. These are some focal wide opacities. So this is an active corneal ulcer right here. Okay, that's going to be pretty evident without a slit lamp. So you'd be able to see that corneal ulcer with the naked eye. That white dot is just going to be very apparent. Okay, this is a patient that has had many corneal ulcers, and now they have scars all over the cornea. So either that's a patient that was wearing their contact lenses and really abused them, and for whatever reason the doc continued to write a contact lens prescription for that patient instead of just making them wear their glasses all the time, or they just got a really gnarly bacterial infection and had a bunch of scars and probably are not in contacts anymore, and probably also have a pretty significant level of decreased visual acuity. Okay, the eye is going to be injected a little bit. They may have some tearing, but the main thing that you're going to note with your patients is they're going to be in extreme amounts of pain. Anytime you have a corneal ulcer, the patient's in a lot of pain. Okay. Maybe some discharge. Most likely that discharge is going to be serous or tears. Hypopion, do you guys know what that is? Hypopion is an accumulation of white blood cells in the anterior chamber. So it essentially looks like a layer of pus on that sinks down via gravity to the bottom of the anterior chamber. I don't know if I have a picture of hypopion at all. But that's indicative that there's some sort of infection going on. The body's shuttling a bunch of white blood cells to the eye, and those white blood cells just accumulate with gravity in the anterior chamber there. We'll talk about hyphema in the trauma lecture. Hyphema is similar to that, but hyphema is blood in the anterior chamber that just sinks down via gravity as well. The focal wide opacity that you may see with the naked eye or under a slit lamp, and then they're going to be really light sensitive as well. You can have a sterile ulcer. We don't really call it an ulcer then, we call it a sterile infiltrate. The sterile infiltrate is going to be the white spot that you see, but there's not going to be any overlying epithelial damage. So when you stain it, it's not going to pick up any stain. You're just going to be able to see the white opacity, but there's not going to be any staining with the fluorescein over that opacity. Okay. All right, not his peas, they're her peas. Herpes simplex keratitis. Yes, you can get herpes in the eye. There are two main types of herpes simplex, type 1 and type 2. Okay, type 1 again is the above the belt type. Type 2 is the below the belt type. So type 1 is what we're looking at with herpes simplex keratitis. The herpes virus will lay dormant typically in, let's see, is it the basal ganglion or the dorsal root ganglion? One of those two, and then zoster stays in the other one. That's not really that important. But herpes can present on the cornea through the trigeminal nerve, which innervates the stromal layers of the cornea, the big sensory layers of the cornea, and can cause quite a bit of pain and some irritation. And it will almost always present with this corneal lesion that's called a dendrite, a dendritic lesion. Okay? If you see that through sodium fluorescein stain, pretty much can stop what you're doing because that's herpes. Okay? Prescribe acyclovir or Valtrex, and the patient will feel a lot better very soon. Okay? So that is almost always what these dendrites look like. I saw one when I was in school doing a contact lens eval on a patient. They weren't really complaining of anything, but I saw something funky without any stain in the eye. So and then I stained it, and I was like, oh shit, that's a dendrite. That's like exactly what they look like. It's literally what they look like. Okay, in that weird sort of dendritic form. Yeah.
Are you going to have a bunch of pictures on the test?
There will be pictures on the test, yeah. None of the pictures are going to be from outside of the slides, and I'm just going to harp on like the main pictures. I'm cutting quite a few of the pictures out because sometimes they don't load with the internet in here. But yeah, some pictures will be on the test. Okay. So with the herpes, these patients are going to be sometimes in pain, sometimes not, because herpes can kind of deaden the corneal reflexes as well. But just like a cold sore around the mouth, you can get the same lesion essentially on the cornea, and that's what that is. Okay. I had a patient in the military that I had to tell he had herpes in the eye, and then I had to tell him that there was two types of herpes. He thought he had an STD. He didn't. And more pictures of the dendrites. You can see the picture on the left is with no stain, and the picture on the right has stain in it. So you don't necessarily need stain to see that dendrite, but stain definitely helps. More pictures of dendrites. Okay. Very interesting. Kind of like almost like a lightning strike on the cornea there. Okay, so how do we treat herpes simplex keratitis? A good rule of thumb is if there's anything wrong with the cornea, I would punt. Okay? If there's anything even remotely close to the corneal visual axis, I'm also punting to the cornea specialist in ophthalmology because I have zero desire to have a patient go blind under my watch and responsibility. I'll make the cornea docs do their job. Okay. But overall, these patients respond really well to oral antivirals. You can use topical antivirals as well. They're much less effective than the orals, and they burn like crazy and cause a lot of extracorneal irritation. And the oral antivirals are typically very minimal in terms of side effects, and they work very well. So I just prescribe Valtrex or acyclovir to these patients, and they respond really, really well to it. If they have recurrent simplex keratitis, sometimes they'll be on kind of that consistent dose to try and eliminate the recurrences, but a lot of times we'll just hit them hard with Valtrex and it'll be good to go until they get it again. Hopefully they don't. So if you don't treat herpes right away, you can get a picture like the patient on the right here. Again, that's going to be real hard to see through. Okay, that's not a happy eye. That's an angry eye. That is a lot of injection. There's a lot of looks like infection going on inside of the eye, and the cornea is very hard to even appreciate there. There is a cornea there, but you can't really see through it, so the patient also can't see through it. You can get scarring in the stroma. We call that disciform keratitis. Okay? That's something we don't want because those scars are permanent, and again, that's going to be really hard for the patient to see through, pretty visually debilitating. So that's viral keratitis or herpes simplex keratitis. You can get bacterial keratitis as well. This is just from bacterial infection on the cornea. Right? Many common causes. Staph, probably the most common, because again, that's part of the natural flora around the eye. So if you get a scratch in the corneal epithelium, you're always at a higher risk for a bacterial keratitis, just because there's a ton of bacteria around the eye. Okay, so again, a lot of these bacterial keratitis will occur from contact lens wear, perhaps trauma, and the patients are going to be typically in a lot of pain. Okay, so symptoms: moderate to severe ocular pain, redness, light sensitivity. That's what photophobia means. Maybe a little discharge. Not like bacterial conjunctivitis, where there's a profuse amount of discharge, that mucopurulent, nasty discharge. This one might just be some tearing. Okay. Redness, obviously, like you can see that cornea is not happy. You don't need a slit lamp to see that. There's an obvious issue there. Okay. Anytime you have bacterial keratitis, just like bacterial conjunctivitis, you're going to treat that with a topical antibiotic. You're going to be much more aggressive with the topical antibiotic, though. So every 1 to 2 hours with the topical antibiotic, with the fluoroquinolone. We don't use topramycin all that often. Usually it's just Vigamox, the fluoroquinolone, topical antibiotic. Okay. Obviously, you're going to want to stop the patient from wearing contacts. That seems pretty self-explanatory, but sometimes it's really difficult to do because patients either don't have a backup pair of glasses, or they're so vain that they just want to continue wearing their contacts because they don't like the way they look in glasses, even though if they continue to wear their contacts, they're going to go blind. That just doesn't very myopic perspective for those patients. So sometimes that's the most difficult part, is you can't wear your contact lenses when you have an active eye infection. It's not going to help. You're not going to treat your eye infection if you continue to wear your contacts. So yeah. And then again, refer to optometry or ophthalmology for really any corneal conditions. Right. This is bacterial keratitis in the picture on the left, and then specifically in the picture on the right, that's acanthamoeba. When I was studying for my optometry boards, paid good money for a study guide. It was worth it to pass my boards. The guy that was leading the study videos, for acanthamoeba, he's like, I always tell my patients, acanthamoeba, I can't believe you went swimming in your contacts. Because that is the bacteria that you're going to get sandwiched between your contact and your cornea, and that is going to eat into your cornea. You can get a corneal perforation with acanthamoeba. It is extremely difficult to treat, even with the strong antibiotics. because it's just a real gnarly bacteria. So don't go swimming in your contact lenses because you might get acanthamoeba. And then I'll have to say,
I can't believe you went swimming in your
Pseudomonas, also very difficult to treat. These next few pictures are like a progression of a pseudomonal bacterial infection. So here's like day 1 for that patient. This is next. Okay, that's going to be real hard to treat. Okay. So I'm sorry.
Does it progress like quickly?
Yeah. Yeah. Look up. You can see like beefy redness there. That's not pink eye. Okay, that's the difference. Also, that cornea is like swollen and probably beginning to scar. There's a hypopion in the back, the background. So you can see there's like this central ulcerated area right here, and then this whiteness right here. That's actually behind this. That's white blood cells in the anterior chamber of the eye trying to fight off that infection. So again, don't go swimming in contacts or acanthamoeba or pseudomonas. Bad things can happen. Okay, fungal keratitis is, for whatever reason, something that you should remember for ants. I think because we treat it a little bit not normally, but you get fungal keratitis from getting some sort of vegetative matter or some fungus in the eye. So if you are hiking outside and you don't have sunglasses on or don't have eye pro on and you get like a tree branch scratching you in the eye, that's going to really hurt. You could potentially have a fungal infection there. Outdoor eye trauma involving vegetative matter. Okay. Could be from contact lens use, but typically you'll get a fungal keratitis after scratching your eye from some organic material. Okay, there's going to be an epidefect, and the epidefect from fungal keratitis is different than bacterial keratitis in how it presents. It's got like feathery margins, where like a central corneal ulcer from bacteria or bacterial keratitis is going to have kind of well circumscribed margins. These are feathery margins, how they're described. But it may mimic bacterial keratitis. Okay, and that is the main thing I want you to remember. Fungal keratitis is actually treated as bacterial keratitis for like the first 24 hours. And then when the antibiotic stops working, or obviously is not working, and the condition's getting worse, then they're going to reculture it and probably suspect fungal keratitis. Hopefully you don't get fungal keratitis because it's very difficult to treat. Antifungals are not nearly as effective as antivirals or antibiotics. At least we have them, but they're still not super effective, and they're pretty toxic on the body itself. But we treat fungal keratitis like bacterial keratitis for the first 24 hours or so. Very similar signs and symptoms otherwise: eye pain, redness, discharge, light sensitivity. Anytime you have a corneal condition, those are probably going to be coming up as symptoms. Okay, so again, initially it's treated as bacterial, and you're going to want to refer this to an ophthalmologist. And again, you're going to want to refer pretty much anything that's on the cornea to ophthalmology. If you have it available, optometry if you don't, and then we'll get it to ophthalmology. But you guys aren't going to want to treat these because there's a good chance that these patients, if they're not treated specifically by a corneal specialist, are going to have long-term vision issues. Don't give a topical steroid. Seems pretty self-explanatory again. You guys shouldn't be prescribing those anyway because you can't monitor intraocular pressure. But you don't want to give a steroid to suppress the immune system when the immune system is one of the main ways that you treat a fungal infection. So here is fungal keratitis at the initial visit. Okay. This is a few days later. So this is a really good example of hypopia here. This is all white blood cells accumulating in the anterior chamber there. That is white blood cells. That's hypopia. Okay. This is the actual site of injury there. That's after 1 week. Okay, this patient had to get a corneal transplant. That's a bummer. And I believe they had a recurrence of the fungal infection. This might be the corneal transplant after it's been reinfected. It's like they weren't able to get rid of the fungal infection, and then the corneal transplant that they had became useless again too. So very difficult to treat fungal infections. Good rule of thumb is to not get one. Okay, so wear your eye pro when you're outside. A few pigmentation disorders in the cornea. Typically these are like a side effect of some sort of medication that the patients are taking. Whorl keratopathy, we'll show on the next slide here. That's due to too much amiodarone usage. Okay, I've seen whorl keratopathy in a patient. Again, it looks exactly like this, kind of whorl-shaped pigmentation in the cornea. Not visually significant to these patients. We just refer them back to who's ever prescribing the amiodarone to have them reduce the amount or change out the drug. And once they do, then that whorl is going to go away usually. Chloroquine and hydroxychloroquine, Plaquenil, can cause some corneal deposits. They also cause macular deposits. So just be mindful. When you're prescribing chloroquine or Plaquenil, there's a pretty well-documented history of that medication now. So the structure for diagnosing guidelines is pretty rigid based on the patient's weight and how long they've been taking the medication. We don't really see too many issues with chloroquine and Plaquenil anymore, but it can leave a deposit. And the other medications can also, again, rarely do these corneal issues cause any sort of vision loss or any visual defects, and they usually resolve once we get the patients off the medication. Okay, here's a picture or the slide for recurrent corneal erosions. My refractive surgery patients, especially my PRK patients, when you wake up in the morning and it feels like you just scratched the crap out of your eye, this is what you have. You've had a recurrent corneal erosion. What happens at night is that your eyelids are kind of adhering to the corneal epithelium, the new epithelium that's grown in after refractive surgery. The epithelium doesn't adhere itself to the underlying corneal layers as well as it used to because you've just ablated a lot of the cornea away. And it will adhere rather to your lids. So when you open your eyelid, when you wake up in the morning and that alarm goes off, you're like, I gotta wake up. And you're like, oh man, my eye really hurts. They hurt like the absolute dickens. I had a lot of RCEs for my first several years after PRK. I was able to train myself when I was waking up to wake up and not open my eyes because they hurt so much. And I would kind of just move my eyes around a little bit, gently, and then very gingerly open my eyes. And then I wouldn't have an RCE, and I would just hydrate my eyes with some artificial tears. Every now and then, if I'm real dehydrated, I'll get an RCE, and they're very painful. They go away because the epithelium will re-epithelialize. And usually I just put an artificial tear in and I'm good to go after 30 or so minutes. But they're extremely painful and you feel like you're going blind. So a lot of times these patients will call in the morning or they'll come to sick call in the morning and they're like, I have a really sharp pain. I woke up, my eyes hurt. And it's usually just one eye, okay? And then you ask them all the questions. You have any discharge? You do anything? If you had refractive surgery, I'd be like, yeah, I did recently. You know, okay, it's probably just a recurrent corneal erosion. Here's some artificial tears. Go see optometry, ophthalmology. They'll double check to make sure everything's okay. They really do hurt quite a bit. This next slide I did not create. It's supposed to be depicting what are called hemidesmosomes, and these are found in that second layer of the cornea, Bowman's membrane. Okay, don't write any of this stuff down. But what these molecules here do is adhere the epithelium to the stroma and Bowman's membrane. And when you get PRK, specifically PRK, they're removing the corneal epithelium, exposing Bowman's membrane, and then they will use that laser and blast through Bowman's membrane into the stroma. So you don't have Bowman's membrane anymore when you have PRK. So you really only have like 4 layers of cornea after you have PRK. And because you don't have those hemidesmosomes there anymore, the corneal epithelium has a harder time adhering itself to the underlying stroma. I've been teaching this for 3 years, and I have no idea what the ice skate reference is on the side there, but the hemidesmosome picture is pretty cool. Good figure skater, I guess. All right, again, you may see an epithelial defect when the patients come into your clinic. It may have already healed, but the patient's still going to be pretty concerned because they had like a 7 out of 10 pain when they woke up. So you may not see an epi defect. Again, that's kind of where your case history comes into play. For patients that are getting these all the time, like every single day or multiple times throughout the day, we may prescribe them aggressively with artificial tears and try to reteach them how to open their eyes or how to blink. That's really, really difficult to do. We may also prescribe, it's called Miro 128. This is like essentially a saltwater solution that's supposed to aid in like adhering the epithelium down. It really dehydrates the cornea, and it also, you're putting salt water in the eye, and that really burns. So patients don't use it. Like, you can prescribe it all you want, but patients are going to be in more pain when they use it, so we don't often prescribe it. There's poor compliance with patients. We can put a bandage contact lens on the eye, so it's basically just a contact lens that we're slapping over so that when they blink, they're not rubbing the exposed stroma. And then they can try to re-go in with the laser and like actually make little holes in the stroma that will allow the epithelium to kind of re-grasp itself in there if they have really severe cases. But a lot of times, the patients are going to be fine after a year or 2, which kind of sucks, but again, I think it's still worth it in the long run. I had PRK in 2008, and I still have great distance vision. So get it if you want it. Don't be afraid. It's worth it. Okay, this is a picture of a big recurrent corneal erosion. That's painful. Okay, let's talk about keratoconus here. A disease of unknown etiology that causes a progressive thinning of the central cornea and is degenerative in nature. Okay? I only read things when they're important. Otherwise, I try not to read verbatim off the slides. Keratoconus, essentially, kera again is the corneal prefix, and conus just like a cone shape. So we've got essentially a cone-shaped cornea. That's not what it's supposed to look like. It's supposed to be perfectly spherical. If it protrudes out into a cone, that's not a good thing. That's going to cause changes to the patient's prescription, because again, the cornea refracts a boatload of light, and it causes a bunch of irregular astigmatism as well that may not be able to be corrected with glasses. Okay? Cause scarring, blindness, and then eventually, if that cone protrudes so much, the superior cornea is going to become so thin that it actually perforates, and that's not a good thing. Okay, so they may need, patients with severe keratoconus may require a corneal transplant to not have that cone shape anymore. Munson's sign, you can see here on these pictures. Okay, when that lower lid bulges out like that, that's called Munson's sign right there, because Munson decided to name it Munson's sign. Remember that picture with the subconcheme, the guy that I had come in, that gnarly subconcheme? He actually kind of had a Munson sign on his lower lid as well. Go back and look at that picture. But that's what Munson's sign is. Okay, the cool thing with keratoconus and technology is that we can diagnose keratoconus a lot earlier than what we used to be able to diagnose it as. So if you're coming in and you have moderate to significant amounts of astigmatism, we're going to do additional corneal scans when you go to the optometry clinic, and we're going to do an elevation map or a topographical map of your cornea. And the machines that we have now, we're able to use the computer software to determine your likelihood of progressing into keratoconus, so we can have like pre-keratoconic patients or like real early keratoconic patients, which is great because then we're going to refer you to ophthalmology, and ophthalmology is going to do what's called corneal cross-linking, and that basically just freezes the cornea in place. It makes the cornea extremely rigid, and it prevents the cornea from continuing to protrude out. So corneal cross-linking has been a great thing. The FDA approved that several years ago, and we're doing that quite a bit in the DoD now. Keratoconus used to be a disqualifier from entering military service, and now it's not. If they're stable with after cross-linking, the civilians can enter military service with keratoconus. Okay, Arcus is a gray, whitish kind of line around the periphery of the cornea. A lot of times you'll see this in older folks, like 70s, 80s. If somebody looks like they had an iris transplant and their eyes are blue and they're 80 years old, they probably didn't. They probably just have Arcus around their eyes. Okay? See this a lot in old folks, older folks, the geriatric population, if you will. We'll also see this sometimes in patients with increased levels of cholesterol. So if you're 80 years old and I see Arcus on you, I'm going to consider that normal. If you're 30 years old and I see Arcus on you, I'm going to order a lipid panel because you probably have high cholesterol. And that cholesterol is depositing itself in the cornea there. Doesn't really affect vision, but if they're under 40, we need to check those lipids because that can be bad. Here's more Arcus, okay? And don't worry about cataracts, I'm going to talk about them later. Any questions with the cornea? Sweet. Let's get started for the next 7 minutes on lecture 6, scleritis and uveitis. Okay, and these are the inflammatory disorders, iritis, scleritis, uveitis that we're going to cover. All right. So again, the sclera from anatomy is the white part of the eye. You want to think of it just as the white part of the eye. That's perfectly acceptable. It protects the eye, okay? Provides an attachment for the extraocular muscles. And there's really kind of 2 layers to the sclera. There's the sclera itself, and then there's a layer above the sclera that we call the episclera. And then above the episclera is the conjunctiva. So if you're looking at the patient's white part of their eye, it goes conj, episclera, sclera. Okay? And all 3 of those layers can get infected or inflamed. Conjunctivitis, episcleritis, scleritis. Okay? Again, this is just talking about the episclera. Anatomy does not really break down the episclera here, but you can see the sclera there. Okay, so episcleritis is something that you're going to see fairly commonly. Most of the time, the episclera is just going to become inflamed because the body's angry at something, okay? But it's just an idiopathic condition most of the time, right? It could also be associated with some systemic disorders, okay? But most of the time, it's idiopathic. And the way that you're going to appreciate episcleritis is you're going to have an acute area of redness. So this acute area of redness, when there's no redness up here or down here, this acute area of sectoral redness is episcleritis. The patient's going to be in a little bit of pain, okay? A little bit of pain, but not no pain. So if they just have regular red eyes, they're from dryness, they're probably not going to be in pain. So episcleritis will present with a little bit of pain, but everything else is going to be pretty normal. Visual acuity is going to be pretty normal. They're not going to have any discharge. Okay? The inside of the eye is going to look pretty normal, quiet. You're just going to have that one little area. Here's some pictures again. Yeah, the picture on the bottom has a little nodule to it. You can see the episcleritis in this patient here nasally in both eyes. Here's more episcleritis. Okay, so the big thing to take away from this slide is that when you're diagnosing and doing your workup, you'll want to administer phenylephrine, topical phenylephrine, 2.5%. Because if you administer topical 2.5% phenylephrine onto an eye with episcleritis and you wait 15 minutes, it's going to look like they don't have episcleritis anymore. All of the redness is going to disappear, the vessels will shrink up, okay, and the episcleritis is going to be gone until the phenylephrine wears off, and then it'll come back. And that is how you diagnose episcleritis. You use 2.5% phenylephrine, the vessels will blanch, and then you know it's episcleritis and not an underlying scleritis. Okay. How do we treat it? You're going to punt this because we're going to put the patient on some topical steroids. Yep.
So the phenylephrine wouldn't mess with the conjunctiva?
Nope. Yeah, and like conjunctivitis isn't going to necessarily have pain. They're going to be irritated at the eyes, but there's an actual level of pain with episcleritis that they don't have with conjunctivitis. Yeah. And then conjunctivitis typically has excess discharge as well. So that's one way to differentiate between the two. Okay. So a lot of times, if it's mild, the patients aren't even going to come into your clinic. If they're coming into your clinic, they're probably uncomfortable. I typically, if I have something that I can prescribe to a patient to alleviate their discomfort, I'm going to give it to them. So that's when we prescribe the topical steroids for episcleritis. I'm not going to go over this. You guys can. This is going to be very similar to how your test questions go, though, vignette style like that. Okay. So, doesn't say anything about phenylephrine in here. You might think this is episcleritis here. Okay, it's not. Put a trickster question in there. It's actual scleritis. Yep.
Can you just use Lumify?
Lumify? Yeah. Not to treat the scleritis. So Lumify is not phenylephrine, and while it may get rid of the redness, it's not going to be treating the episcleritis. And we're not using the phenylephrine to actually treat the scleritis. We're just using it as a diagnostic tool. Lumify is great, and definitely use Lumify if you have red eyes. Don't use it all the time. Never use Visine or any of the tetrahydrozoline products because those will create like a hypersensitivity where you always have to have it or your eyes are going to be bright red. Lumify is actually a glaucoma medication, and it works really, really well. Have you used Lumify? It's so, do you like look in the mirror and watch your eyes get white in real time? Lumify is crazy. If your eyes are red, just because they're injected, because they're dry or you're tired or whatever, you put a drop of Lumify, and you can buy Lumify over the counter. You put a drop of Lumify, and you can literally watch your eyes go from red to white in like 15 seconds. It's one of the coolest things I've ever seen. And Lumify does not create the hypersensitivity that Visine does. So I'm a big Lumify fan. I wouldn't use it all the time, but like if you want white, pristine eyes, Lumify is the drop for you. And again, that's over the counter. Before we hop into scleritis, let's take 10, and then we'll jump right into that. Okay, so we're talking about episcleritis, mild pain, kind of sectoral area of redness, blanching with phenylephrine. Now we'll move into scleritis. So again, The episclera lies above the sclera. The sclera is the white part of the eye. Okay, a lot of times if you have episcleritis, you recall it's idiopathic a lot of times. If you have scleritis, less often is it idiopathic and more often is related to some sort of inflammatory disorder inside the body or a subsequent infection. Syphilis, I think that's supposed to say syphilis. It's not a new disease there. Hey, go back here and let's see our slides. Man, syphilis. Okay. So signs and symptoms for scleritis. Typically, the hallmark signs and symptoms are going to be a severe or a deep boring eye pain. Boring, like Elon's Boring Company, where they're digging holes into something. Like someone's digging a hole, not boring like you are listening to me. Right? Deep, boring eye pain digs into the eye. It'll radiate. It's going to be much more painful than just regular scleritis. Okay? Typically, there's an inflammatory aspect to scleritis. You're going to see not just redness and irritation, but an inflammatory response inside of the eye as well. There'll be light sensitive, maybe tearing, some decrease in the vision, and then the cornea, the sclera rather, is going to have a bluish hue to it as well, and that's due to the fact that the sclera is thinning, and you're actually able to appreciate the underlying choroid, that blood supply that supplies the retina. That lies underneath the sclera, so if the sclera is too thin, you're going to see the blue hue from the choroid. Okay, a couple different types of scleritis. Probably useful information if you're in an eye care clinic. In my opinion, this probably goes a little too deep into what you need to know about scleritis. You're not really going to be treating scleritis, you're going to be punting this to ophthalmology so that they can treat it. Okay? But there are a bunch of different types of scleritis, anterior, posterior. You can be necrotizing, so like this, again, that's what gives the sclera that blue appearance because it comes too thin. Okay? And then more on posterior scleritis as well. Obviously, if you have something happening in the back of the eye, there's some pretty sensitive things back there, like the optic nerve, so vision can become an issue and more tender. This next picture is a picture of the blue hue to the sclera. Okay, so that sclera is becoming thin, and then you're able to appreciate the choroid underneath the sclera there. More of that blue hue here. More blue. It may not be blue, it might just be beet red. Okay? Now, if you put phenylephrine on this eye, that phenylephrine will not blanch. So you put phenylephrine in this eye, thinking maybe it's episcleritis, or hoping it's episcleritis, because it's much easier to treat. You wait 15 minutes, the eye's going to look exactly like this. And that's going to be because it's scleritis, not episcleritis. Okay? Here's a nodular example. Posterior scleritis. We're looking at the inflammation behind the eye there. Okay, so again, the workup is going to be similar in terms of episcleritis versus scleritis. You're going to put that phenylephrine in, 2.5%, and the vessels are not going to blanch. Okay, so you're still going to have that redness, right? That's typically how you can determine whether it's scleritis or episcleritis. Obviously, scleritis, the patient's going to be in much more pain as well. All right, so if they have scleritis, if those vessels don't blanch, now we need to figure out why they have scleritis. So that's where you guys are going to do more of that physical examination. You're going to order a bunch of labs to figure out what's wrong with this patient. And then once you've got those ordered, you're going to punt that patient over to ophthalmology. Okay. Ophthalmology is going to treat them. I'm going to punt these patients over to ophthalmology as well because I'm a primary care doc and they're the specialists. I'll let them deal with the special things. They're going to do steroids probably with these patients, maybe some NSAIDs. Yeah, they're going to treat that, not me. Okay, they're going to do more specialized treatments if it's more severe, so necrotizing scleritis is going to get potential scleral grafts, because you can't have a thin sclera. Okay. And then treating any other conditions that may be causing the scleritis to happen. Okay, this next chart, pretty useful. It's going to compare the conjunctivitis, episcleritis, and scleritis. Okay, so it's got pain, discharge, redness, when it happened, and any systemic symptoms. Okay, so if you're wanting to compare and contrast the conj to the episclera to the sclera and the inflammatory or infectious disorders that occur in each of those, this is a good chart to use. Okay, now we'll move on to the uveal tract. This is kind of the area of the eye that has blood supply to it. So we're thinking three main components to the uveal tract. We've got the iris. Obviously there's blood supply in the iris because that's a muscle. We've got the ciliary body, okay? And again, there's a muscle in the ciliary body, the ciliary muscle. That's what allows the eye to accommodate or look at things up close. And the choroid is just blood, okay? Obviously there's a blood supply there. So if we have any sort of inflammatory condition in any of those areas of the eye, we term it as uveitis. Again, iris, ciliary body, choroid, all three of those areas of the eye can get a uveitis. Anterior uveitis is typically talking about the ciliary body and the iris, and you can have intermediate, but most of the time it's just anterior and posterior uveitis. Posterior would be in the choroid. Okay, again, we've got case studies here that you guys can go through on your own time. This is a picture of what's called chorotic precipitates. So we've talked about hypopyon being the accumulation of white blood cells settling inferiorly in the anterior chamber. If they don't settle in the anterior chamber, sometimes they can adhere to the inner lining of the cornea, the endothelium, and they'll just stick there. Chorotic, again, chara meaning cornea, and precipitates, something's precipitating or sticking to the backside of that cornea there. So we call those chorotic precipitates. That's indicative of some sort of uveitis, okay, whether it's iritis or choroiditis, cyclitis. All right. So with iritis, an iris infection or iridocyclitis, that's an inflammation of the iris and the ciliary body combined. Typically, the first, just like with the subconj heme, if you get uveitis once, I don't care. I'm going to treat it and send you on your merry way. When you're coming in constantly with some sort of iritis or uveitis, then we need to figure out why. Your body has some sort of inflammatory disorder going on. A lot of times those are HLA-B27 syndromes, okay? Could be some sort of iritis, some sort of either autoimmune or inflammatory disorder is causing an inflammation in the eye. So these are fairly painful conditions. Uveitis is painful, and there's inflammation going on actively inside of the eye. A lot of these patients are going to be light sensitive, okay? The light sensitivity comes in because if you think about going to the gym, and you haven't been to the gym for a long time, and let's say you do a bunch of bicep curls, and you wake up the next morning and your muscle's sore, because that muscle's inflamed, right? So the same thing can happen inside of your eye to your iris. Your iris can become inflamed, and every time light enters your eye and your iris is constricting down to limit the light, or you go into a dark room and your iris dilator is moving, those muscles are inflamed. It's going to be painful for that iris to actually move. And whenever you have a painful iris, that's going to naturally make your mind think that you're light sensitive. So the light sensitivity aspect, the photophobia with a uveitis, is due to the fact that the iris is inflamed, and every time that muscle moves, it hurts, okay? So one of the ways that we alleviate that pain with uveitis patients, sounds counterintuitive, but we actually dilate them. okay? Doesn't make sense to dilate a patient that's light sensitive unless they have uveitis, in which case they're not really light sensitive, it's just the iris is painful every time it moves. So if we paralyze that iris from moving at all by dilating it, then they actually become less light sensitive and they just wear sunglasses for the brightness, okay, for the true light sensitivity. Okay. That took a long time for it to make sense. Hopefully that makes sense to y'all. Chorotic precipitates we talked about already, potentially a decrease in the vision. Sometimes patients with uveitis will actually have a lower intraocular pressure as well, which also sounds kind of counterintuitive. You think if there's inflammation going on inside the eye, that it would increase the pressure inside of the eye. It actually decreases it, and we'll cover more of that in glaucoma, but basically when you have inflammation inside of the eye, it actually opens up the drainage system in the eye, which allows more of that aqueous to flow out. We'll talk about that more in glaucoma lecture. Okay, so we may see some cells, some white blood cells actually floating around in the anterior chamber when you're underneath the slit lamp and you're looking at the patient's eye, pushing beyond the cornea, but just in front of the sclera. We're looking at the aqueous, the liquid inside of that anterior chamber, right behind the cornea. You'll see the white blood cells actually floating around in there. Sometimes you can see some protein particles floating around there. We call that flare inside of the eye. It just looks like a little flare of protein. You got cells, flare, you may have hypopyon, may have an irregularly shaped pupil. If the pupil is, or if the iris is sticking to the cornea or to the lens behind it, that's going to cause an irregularly shaped pupil. Maybe you'll have some nodules on the iris as well. Okay, so the ciliary flush or circumlimbal injection is also one of the signs that we'll see. So this eye is pretty red all over. Okay, so this isn't a great picture, but this one, pretty white down here, except for the area right around the cornea. That's the limbus, and that limbal area is injected. That's really indicative that there's a uveitis going on with this patient. Okay, we've seen this picture already. This is chorotic precipitates, more KPs. Okay, so those nodules we were talking about, the Queppy nodules. And the irregularly shaped pupil due to the adhesion of the iris to the lens behind it. The iris just gets sticky and it sticks itself to the lens, and that's going to cause an irregularly shaped pupil. How do we work these patients up? Got to figure out what's going on. Again, if you come in once, perhaps it's just idiopathic and you're unlucky. If you're coming in more than once, we're doing a workup, figuring out what's causing this uveitis to occur. Okay, so you're running a bunch of labs, and then you're referring to either optometry or ophthalmology for uveitis. Okay, we're going to prescribe topical steroids, some strong ones that can penetrate through the cornea just into the anterior chamber to calm that down. And again, there's the dilation. The cycloplegic agent, that's called a dilating drop. Cycloplegia is dilation. Okay, more case studies here. So this is posterior uveitis. This is a retinal photo right here. This is not what a normal retina is supposed to look like. Okay, so when you're doing your DOs, don't say it looks like this, because that's not normal. Okay, this white area is inflamed, potentially infarcted retina right here. So it's either got like a vasculitis right here or along this blood vessel that's causing a bunch of inflammation that's infarcting or killing the retina. That's likely the case there. Okay, and that's posterior uveitis. Again, on posterior uveitis, we're thinking the choroid is inflamed, perhaps the retina also, or the vitreous has become inflamed as well. But usually we're thinking choroid for posterior uveitis. Lots of things can cause posterior uveitis. Fortunately, most of these things are not super common. AIDS obviously has many issues with the body, but they can have retinal issues from cytomegalovirus, maybe some autoimmune conditions. But posterior uveitis is not as common as anterior uveitis. Posterior uveitis is much less common. Very similar on signs and symptoms though, except if it's in the back of the eye, now we're not going to see things on the front of the eye like the sporadic precipitates or the cells and flare. We're going to see issues occurring on the retina. Okay, so retina, areas of infarction, cotton wool spots, optic disc might be swollen, retinal lesions. Okay, toxoplasmosis is from cats. Okay, another reason why dogs may be superior to cats. All right, you can get retinal lesions from toxo. Right, that's not a fun area. Fortunately, a lot of times these are peripheral lesions, so they're not visually debilitating. You're just going to lose a little bit of your peripheral vision, but you're not going to notice that anyway. If these lesions are central on your macula, these can be pretty visually debilitating, but this one's far out in the periphery, so not that big of a deal. Still, not a good reason to have a cat. Okay, cytomegalovirus, inflammation of that blood vessel there, that vasculation is, or lack of, is causing the retina to either swell or lose its blood supply, and it'll die. Okay, AIDS, also just probably not a good thing to have. Tougher to live life than if you don't have it. Fortunately, medicine's been pretty great in the immunosuppressants that we have. Still probably not a good thing to get. Okay, cytomegalovirus, as you know, with AIDS, immunodeficiency, so other viruses can take over CMV, herpes, Kaposi sarcoma. That's how you get those things, because your immune system's shot. More retina pictures. Okay, how do you treat CMV? I don't, okay. But that's how. All right, posterior uveitis workup. The main thing you guys need to know here is if there's retinal findings, it's going to get shipped out to ophthalmology. Okay. You guys aren't going to touch that. You may be treating some of these patients for the other systemic conditions that they have, but as far as the eyeball is concerned, ophthalmology is going to handle all of that. Okay. All right, flew through that one. Any questions on those? Big takeaways again with that lecture: episcleritis is area of sectoral redness, maybe a little bit of pain associated. Vasculation, or the vessels are going to blanch with phenylephrine 2.5%. Optometry ophthalmology is going to treat that with the topical steroid. Scleritis, a deep boring pain, maybe a blue sclera. Vessels won't blanch with 2.5% phenylephrine, and that's going to require perhaps some NSAIDs or systemic steroids to treat. And then anterior uveitis, you've got ciliary flush, decrease in vision, the chorotic precipitates in cells and flare floating around in the anterior chamber. Optometry ophthalmology is going to treat that with topical steroids. Posterior uveitis, not anything associated with the cornea so much, but more of the retina. So you can have retinal lesions. And then we need to treat the underlying systemic disorder for those lesions to go away. Try to keep it simple, and then you'll do really well on the test. Okay, last one, lens and vitreous. Talking about the cataracts. I have some patients call them cataracts. I always chuckle. I think that's fun. In addition to cataracts, we're going to talk about vitreal conditions, because you're going to have patients that are also calling your clinic very freaked out about their vision if they have a certain vitreal disorder that we'll talk about. All right, so let's talk about the lens anatomically. Okay, it's clear, and there's 3 layers to it. There's a nucleus, a central nucleus, there's a cortex, that's kind of the middle layer, and then there's a capsule that the whole lens sits in. And that capsule then is connected to these zonules, and again, those zonules are those little string fibers that are connected to the ciliary muscle, and every time that muscle flexes, it allows you to see things up close because it changes the shape of the lens. Until you're about age 40, that's how the lens works. Once you hit the age of 40, again, there's a protein inside of the lens that stops working or stops being produced. That's the alpha crystalline protein. Once that protein is not any more produced, your lens is going to become more rigid. So when you're looking at things up close, the lens won't be able to flex and move, and that's what we call presbyopia. And then also, it's not going to become clear, it's going to become less clear. And anytime you have a lack of clarity in the lens, we call that a cataract. So typically around the age of 40 is when you're going to need your reading glasses. That lens is getting hard, you can't focus on things up close. Then typically around the age of 65 to 70 is when the cataracts become detrimental to your vision and you need to get cataract surgery. Okay. We'll talk about that here in just a second. All 3 layers of the cataract of the lens can develop a cataract. We'll talk about those different types of cataracts. It's going to be important for you guys to know I can't remember if it's important for you to know for my test, but it probably is going to be important for you to know for PANCE, and then after that, probably not going to be important for you to differentiate between different types of cataracts. Just know what a cataract is and that it requires surgical treatment. Okay. So again, capsule, cortex, nucleus, from outside to in, each of those layers can develop a cataract. Okay, so risk factors for developing a cataract. You are alive. That is a risk factor for developing a cataract. Okay? Death, taxes, cataracts. Guaranteed. Okay. There's no magic bullet for cataract treatment. There's no way to prevent yourself from getting a cataract. You're going to get them. Just enjoy them. And then you get cataract surgery and you'll really love life again after you get cataract surgery. There are ways that you can make your cataracts grow faster. If you've got the beets, okay, the diabetes, that will make your cataracts progress quickly. If you're using systemic steroids, that will make your cataracts progress quickly. If you get hit in the eye, that will give you a cataract pretty quickly. Okay? Other secondary things can cause cataracts as well, but typically they're age-related, right? 65 to 70, naturally you're just going to develop a cataract. So the first type of cataract we're going to talk about is a nuclear sclerotic cataract. This is probably the most common type of cataract out there. This is the typical age-related cataract. So this cataract is located within the nucleus of the lens. So again, that central portion of the lens, and that is going to become less clear. So at age 40, your lens is clear throughout, and then the alpha crystalline stops being produced, and gradually, year by year, that lens center, the nucleus, is going to just become a little more yellow every single year. First it's like white yellow, then yellow, and then finally it's going to be like opaque, almost brown. Okay? Those are end-stage cataracts. Now you're looking at this and you're thinking, I can kind of see through that, but there's a little bit of difficulty for me seeing through the direct center of that. The patient's also going to have difficulty seeing out. You can't see in, they can't see out. Okay? Sometimes with these nuclear sclerotic cataracts, the center of the lens is actually swelling a little bit. So the patients will get what's called like second sight. They become more nearsighted, so they actually can see things up close again. They turned 40, they became presbyopic, they couldn't see anything up close. They get this cataract, the center of the lens swells naturally, not naturally, but it swells, which actually changes the refractor shape of the eye, and now the patients can read up close without their reading glasses anymore. They think it's really cool, but it's just a cataract. So these are pretty mature cataracts. Mature not in their demeanor, but how advanced they are. Okay, so it's very difficult to see through this eye right here to the back of the eye. It's impossible to see through this cataract right here. This is like almost a rock inside of this patient's eye right here. That's a hypermature cataract. Believe it or not, the worse a patient's cataract gets, the more difficult it is to surgically remove this cataract. Cataracts are the most common cause of blindness worldwide, too. Worldwide, okay? Obviously not in America, because we can do cataract surgery. But worldwide, cataracts are the most common cause of blindness. Because once you get this, and you don't have the means to get it removed, you're screwed. And everybody gets cataracts. So as people live longer, and they don't have access to first world medicine, they can't get their cataract surgery out. A lot of the ophthalmologists will go on mission trips to South America and do cataract surgeries there, and they're dealing with some of the most gnarly, opaque cataracts. It's very difficult to take these out. Pretty simple stateside because we don't let them get this bad. Moving on, you can get a posterior subcapsular cataract. Okay, this one is often due to steroid use. So if you're on systemic steroids, and all of a sudden you can't see anymore, perhaps you have a cataract and you'll have to get that removed. Again, you can see the age here is earlier than what you would expect for a regular cataract. And then you've got cortical cataracts. So this cataract is happening in the cortex. It has these bike spoke-like patterns to it. These are not necessarily going to blur the central vision like a posterior subcapsular cataract or a nuclear sclerotic cataract would, but rather glare is going to be the most common complaint with these patients when they're driving at night and their pupil naturally dilates. More of that light is going to be shining through, and it's shining through not a clear lens, but like a bike spoke wheel, and it's going to scatter that light all throughout their retina, and they have a really hard time driving at night. So those patients are going to need cataract surgery because their activities of daily living are being interfered with. Another picture of cortical cataracts. Okay, so symptoms, typically, again, it's going to be glare. That's going to be onset first, and then that decrease of vision is going to be a secondary complaint. The reason the decrease in vision is a secondary complaint is because the cataracts progress so slowly that the patients don't even really realize how bad their vision's gotten until they get cataract surgery and they're like, holy crap, I can see colors again. I did not realize that my vision was that bad. So that's kind of fun. My parents had cataract surgery, and my dad especially, he was freaked out about his cataracts. My dad is your prototypical white old man who hates going to the doctor, and finally came to me with concern about his vision. Like, you don't have to wait to call me your son. Just call me about your visual issues. But he waited, and he's freaked out. He's like, can you take a look at my eyes? I was like, yes. Looked at him, I'm like, you just have cataracts. He was very concerned that he was going blind because his cataracts were pretty advanced. And he was having a hard time seeing and driving. And he drives still for a living, so he was really concerned. But he got his cataracts out, he's like, holy crap, I can see so good. He doesn't need glasses for distance anymore. Like, his whole life changed. And I patted myself on the back. I didn't do the surgery, but I did refer him to a great cataract surgeon. So, but yes, glare and loss of vision will be the main symptoms with these patients. And this picture kind of explains what the symptoms might look like to you. So cloudy vision, halos around light, kind of a yellowing of the colors, trouble seeing at night, bright light sensitivity, maybe some double vision. So how do we treat cataracts? If they're early enough and we can still correct the vision, we're going to do that. As soon as we can't correct the vision, and the best corrected visual acuity, that's what BCVA stands for. As soon as the best corrected visual acuity is 20/40 or worse, And that's either by regular visual acuity, reading the chart, or me shining a light into your eye while you're trying to read the chart. We call that the glare test, trying to simulate nighttime driving there. And they have like a documented chief complaint of, I can't do my normal activities of daily living because my glare is so bad. Then they're gonna get cataract surgery, okay? Cataract surgery is the most commonly performed surgery in America. It's also the most successful surgery in America. And the goal of cataract surgery is to decrease your overall use on glasses. They do a great job. These surgeons are doing on a big, I'm thinking like Phoenix, where there's a ton of people that get cataract surgery because there's a ton of retirees that live in Phoenix. They're doing 60 to 70 cataract surgeries a day there. That's pretty awesome. They'll do one eye at a time. So they'll do your worst eye first, then they'll have you back like 6 weeks later and they'll do the fellow eye. This is a picture of an intraocular lens. So what they do is take the lens out, the cataract out, they'll remove it. And I have a video here. This is a good one to watch. They make an incision in the cornea, they juice up the lens essentially with this phacoemulsifier. It kind of sends ultrasonic sound waves through the lens, it breaks it all up, and they suck that out, and then they'll put the new intraocular lens in place. And this new intraocular lens actually has the patient's normal prescription in it, so then they don't have to wear glasses. Typically for distance vision, they can correct you for distance vision, they can correct you for reading, so you just put distance glasses on if you read most of the time, or if you drive, they'll correct your distance vision, you just put readers on. Or, now they have multifocal intraocular lens implants, where some patients, if you're not type A, can get by with no glasses at all. Type A patients don't get those because they are anal about their vision. It's got to be perfect, and glasses are the only way that they're going to get that perfect vision. But if you're not type A, you can get a multifocal IOL and probably not need glasses at all. Let's see. These are concerns from a surgical standpoint. If your eyeball is not stable, they don't want to do cataract surgery on it, but most patients are able to get the procedure done. Okay. Future treatments, drops, probably not. All of those are homeopathic things and they don't work. A couple other things listed here. Overall, the bottom line, surgery is the main treatment here in America and worldwide, and that's probably not going to change in our lifetime. Okay, congenital cataracts are bad. If you have a kid that comes in and they have leukocoria, a white pupil, that's a bad thing. We want to get that cataract out emergently because we want to prevent amblyopia. Very good. Thank you. All right. It's hard to test vision on an infant, okay, because they can't read. So you've got to look for other things. Leukocoria is one of the main things you can look for. So that white pupil. You shine your pen light in the patient's eye, and if it's got a white reflex instead of a red reflex, that is leukocoria. Okay. Urgent medical condition, okay? So we need to get that surgically removed and replaced. I had a patient who had a congenital cataract. It was like a 6-month-old baby, so they had already taken the cataract out, and we, you don't put a new IOL in those patients because they're young. So they wait to put an IOL, the intraocular lens, into patients with congenital cataracts until they're in their teens, because the eyeball is still growing, and they want to make sure the eye's done growing before they put the lens in. So we instead will either put glasses on that patient or a contact lens. Typically, you don't put glasses in a patient with a cataract, a congenital cataract, because the lens is gone. So that makes the patient like about a +15, which is like a lens that's this thick, and it's super duper heavy sitting on that patient. So instead we'll put a contact lens on. Now, fitting in a 6-month-old in a contact lens, extremely difficult, right? That 6-month-old is not putting the contact in. So you got to train the parent, who's already probably a little nerve-wracked about their kid and their kid's vision. You got to train that parent on how to properly put a contact lens in their infant. A lot of times we'll put in night and day contacts, or contacts that the patient can sleep in. Still not great, but it's authorized for use so that we're not constantly putting a contact in and out of that infant's eye. But we've done that here at the TMC. It's fun once you're done with that patient, because the parents are super happy afterwards and the kid's able to use both of their eyes as they're supposed to. It's a nice, fun story afterwards. It's pretty difficult while you're doing it because there's a lot of baby crying and that's not enjoyable. Okay, off of that, talking about lens position anomalies. Two types that we're talking about. You can either have a subluxed lens or a completely dislocated lens. Definitions to this are: a subluxed lens is still connected partially by the zonules. A dislocated, it's completely dislocated from the zonules. Okay? Hard kind of to differentiate whether you have a subluxation or a dislocation, unless the lens is completely in the anterior chamber. That's going to be dislocated, right? If it's still kind of in place, it might be subluxed, it might be dislocated. Hard to tell. But I'll show you some pictures coming up here. How do you get a dislocated lens? Trauma, usually. Got punched in the face, and my lens got jacked up. My zonules got ripped. Okay. Some connective tissue disorders, Marfan. The zonules just sort of don't work. And a couple others listed here. You're going to have some vision issues if your lens is dislocated or subluxed. Okay? Hopefully that makes sense as to why. Again, the lens is a third of the refractive power of the eye, and if it's moved just off a little bit, you're looking through several diopters of lens change. It's like 16 potentially clicks on my which is better 1 or 2 wheel. That's a lot. Okay? You'll also probably have a little bit of monocular double vision. When patients come into your clinic and they say they have double vision, it's really important that you differentiate whether it's true binocular double vision due to like an eye turn, or it's monocular double vision. Most of the time, it's not double vision at all, and it's just like blurred from dryness, okay? But sometimes patients will have a true binocular double vision where the eyes turn. So when you ask the patient, if you close one eye, does the double vision go away? And they'll be like, yes, it does. That's binocular double vision. If you ask them to close an eye and it doesn't go away, that's monocular double vision, where they're actually seeing 2 separate items. And you really have to be specific when you're asking your patients these questions. Like, do you see 2 separate items? Or do you see just like a ghosting or a shadowing around the items? Okay? You have to be specific in the way you ask patients questions about their vision, because they're just going to say I have double vision, and they really don't. If they do have monocular double vision, you want to ask, is it recent? What's the onset? And was there any trauma? Because if there was trauma and they have monocular double vision, we're thinking potentially they have some sort of lens position anomaly, whether it's dislocated or subluxed. Okay. This is a picture of potentially a subluxed lens. Actually it is, because you can actually see those zonules are still attached. This is a picture of a completely dislocated lens. There's no zonules because that lens is in front of the iris. It's supposed to be behind the iris. Okay, that lens is in the anterior chamber, not where it's supposed to be. Okay, we talked about the workup already. What are we going to do if there's a lens position anomaly? I'm not doing anything. You're not doing anything. Ophthalmology is going to do it all. Okay, they're going to remove the lens potentially, or try to put it back into place if they can. Probably they're going to remove the lens and either put an IOL in, or they may put the anterior chamber lens in as well. They kind of sew a lens onto the iris. All right, let's talk about flashes and floaters here. Should be able to get through these. Flashes and floaters are another thing that patients are going to call your clinic really, really freaking out about. Subcontinues, flashes and floaters. Patients are going to be freaking out because it's not normal things to their vision. And the second most important thing to patients, aside from being alive, is their vision. Okay? So anytime a patient's vision is affected, they're going to be freaked out. if you have a bunch of new floaters in your eye that you don't normally have, things floating around in your vision, or if there's a ton of flashing lights going on and nobody's flashing the lights, there's an issue with your retina. Your retina may not be detaching. You may just have an issue where your vitreous, the jelly inside of your eye, is tugging and pulling on the retina. And anytime you get tugging and pulling on the retina doesn't have any pain receptors. If you tug and pull on your skin, you can feel that. If you tug and pull on your retina, you won't feel it, but you're going to see it. There's photoreceptors in the retina. So anytime the retina is really excited by something out of the ordinary, it sends off flashes of light. Okay? And then floaters come in naturally. There's two types of floaters, normal ones, not normal ones. Normal floaters, again, are a part of the vitreous, and that's that jelly inside of the back of the eye that keeps the eye nice and round. Normally it's clear. As you age, the vitreous liquefies, and it sort of clumps together, and these little clumps will float around in your vision, and they look like little hairs or little cells. Okay? Again, I told you, don't go looking for them. You don't have them, because you probably do, and you'll drive yourself crazy. The other type of floaters are if there's bleeding in the vitreous and blood appears to mimic floaters. So I always ask patients if they're complaining of flashing and floating, flashes and floaters, does it look like someone's shaking salt and pepper over your vision? If they say yes, that's an abnormal amount of floaters, and there's something wrong with the patient's retina typically there. Okay? So flashes and floaters, not normal. Suggests there's traction from the vitreous onto the retina. Flashes can also occur kind of with a migraine. Anybody get migraines in here? Anybody get the aura? What kind of aura do you have? Like it's, oh, the pinwheel?
No, not pinwheel, but like little flashing lights.
Okay. Anybody get lightning bolts? Lightning bolts? Yeah. Anybody get a kaleidoscope?
Yeah, circle rainbow.
Yeah. There's only a couple types of auras, and they are very descriptive. Patients will get a lightning bolt in their periphery. Sometimes you can get a kaleidoscope that starts, I had an ocular migraine once because I was charting, and I hate charting. I had a kaleidoscope start in the center of my vision, and I was not under the influence of drugs. And it got bigger and bigger and bigger, and it lasted for about 20 minutes. And it was one of the most surreal feelings because I could still see things behind the kaleidoscope, but I also really couldn't see things behind the kaleidoscope. My wife had one of these while she was driving, and I told her she should probably pull over and wait half an hour. She did, and it got better. And then you can also get, like you described, kind of like either an aura or little dots or flashes off in the periphery as well. Those are not necessarily flashes, that's more of an aura that's either followed up by a migraine. Did you get the headache after?
Yeah, usually it's like
Yeah. Pop that Excedrin then. Sometimes you won't get a headache after that, and we just call that an ocular migraine. It's like, yeah, it's a migraine without the actual headache, just an ocular migraine. Not really a flash of light, but also kind of freaky. Okay, I want to talk about a posterior vitreous detachment. Normally, again, the vitreous is adhered to the retina. As you age, it liquefies and it shrinks down and it pulls itself away from the retina. That is also pretty normal, okay? When it does that, again, there's no pain receptors on the retina. You're going to get flashes of light. So that's your flashes of light. And then there are some areas of the retina that have stronger adhesion points than others. The most strong adhesion from the vitreous to the retina is around the optic nerve head itself. So all of the rest of the vitreous is contracting off the retina, except for that little area around the optic nerve. And then finally, when that detaches, you're going to get a brand new floater smack dab in the center of your vision. It's a round circular floater in the center of your vision that is very visible to patients, and they will be freaking out. They're gonna get a bunch of flashes of light, and they're gonna have a fat floater right in the middle of their vision. And those patients are going to be freaking out. They've had a posterior vitreous detachment. Okay, they're gonna call you, and they're gonna say, I can't see. I have flashing, there's something in my vision, I can't blink it away. The bottom line for those patients is have them come to optometry ophthalmology. We have to dilate those patients to make sure that the vitreous didn't tear a hole into the retina. Okay? A vitreous detachment is not a bad thing. It's pretty normal. The brain is actually going to learn to ignore that floater that's sitting in the center of your vision. Okay? Just like your brain ignores your other floaters until you go looking for them. Okay? So the floaters don't go away, your brain just ignores them. The brain is awesome. But we do need to make sure that there's no hole in the peripheral retina, because if there is, then fluid can get behind that hole, and then you can get a retinal detachment, which is a bad thing. Okay, retinal detachments are how you lose vision. But a posterior vitreous detachment is not a retinal detachment. Okay. Okay, we talked about floaters, blurry vision, causes for vitreous opacities. Again, just being alive is a cause for vitreous opacities, or trauma, perhaps. But usually it's just the vitreous kind of liquefying as you get older and clumping together. Here's what vitreous opacities look like. When you guys are on the slit lamp, perhaps, if you were savvy on your slit lamp, you could see the lens in the center of the pupil there. And if you push just behind the lens, you can actually see the anterior vitreous. If you really want to appreciate the vitreous the next time you're using a slit lamp, which I'm sure will be soon, you can have the patient shake their eye up almost like a magic 8-ball. So have them look up, down, left, right. That'll get that jelly inside of the eye shooken up, and then you'll be able to see the floaters passing through the light as they're flowing by. Okay, those are vitreous opacities. For severe floaters, you can get a vitrectomy. Not super common to do because they're putting 3 ports in your eye, they're sucking the vitreous out, and they're pumping aqueous back in. So again, because the brain is pretty smart at ignoring those floaters, your floaters have to be like, prohibiting you from doing anything before they'll do a vitrectomy, but they can do a vitrectomy. Don't tell your patients that though, because they'll be asking for vitrectomies for a tiny little floater, and they'll be disappointed. Okay, a couple of case studies at the end of this. That again, how your test is going to be formulated. Perhaps you'll have some pictures on the questions on the test. There are pictures on the test, but not each question will have a picture. Okay. This is the ring with a posterior vitreous detachment. That circular area used to be attached right here to the optic nerve head. Okay, we call that a Weiss ring. That's the floater that the patients are going to see after they have a posterior vitreous detachment. Any questions? 2 for tomorrow. I will see you all at 8.